either you utilize it with distalization, so you move everything back on the upper arch and on the lower arch. This is a lot more challenging than single arch distalization. So double arch distalization is going to be more challenging because it's hard to control the root axis, it's hard to control the palatal cusp on the upper arch, and it's hard to control the root inclination on the lower arch. Or either in more severe cases, we do extraction. So what are some of the protocols you can amend to in treatment planning for either distalization or extraction? ClinCheck is not hard to modify or review. I think the most challenging thing is to do treatment plan for your patient and what treatment plan is good and ideal for your patient. As long as you have the ideal treatment plan, the ClinCheck will become a lot easier. So in crowdings less than 4 to 6 millimeter, it's good to tackle it with distalization. Anything more than 6 millimeter, you tackle it with extraction. That means 1 premolar or 1.5 premolar is required to resolve the problem. And if the nasolabial angle is less than 90 degrees, that means it's very procumbent, the upper lip is very flaring, and the lower incisor angle is more retrocline, okay? And with a low facial height, those are the criteria for distalization. However, there's another key that you can take note of, the lips. In patients with thin lips, you can tackle it with distalization, no problem. However, if they have very thick lips, even if the crowding is within 4 to 6 millimeter, you need to communicate with the patient. What are their main concerns? If the main concern is aesthetic, then maybe you need to suggest a treatment plan with extraction for the patient. Because with thick lips, for every 4 millimeter of retraction, you're only going to get 2 millimeter. Because the soft tissue, the soft tissue will also account for the retraction as well. And patients with more growth, that means they're younger, you can do distalization and do less extraction. However, in adults, we tend to do a lot of extraction because there's no growth. The chin, the nose won't grow. And the bone is more mature, it's hard to move within the arch bone. So according to the Invisalign, the default protocol is they move 7 halfway, and then 6 start to move, and then 5, and then 4, and then 3 to 3. That is by default. However, I try to change a little bit to save a few aligners, about 5 to 10 aligners. So I will move 7 halfway, and then I'll start to move 6. And after 6 and 7 are at its final position, that means they have a very good anchorage on the posterior segment. I start to move 4 and 5 together. And then halfway, I will try to move 3 to 3. That is one of my way to save some aligners for my patient, and then the treatment time can be reduced by about 5 to 10 aligners, sometimes about 15. So it's very critical if you have a busy practice, and this is gonna save you a lot of time. So this is how I do it. So I'll move 7 halfway, and then I'll start to move 6. So you can see that the plastic will tuck inside all this spacing. And that is where the retention comes from, and that's where the teeth is able to distalize. Not because of the morphology of the 6 and the 7, but of the plastic in between that will increase in size, that will help move the molars distally. So it's actually this surface area here in the interproximal and the surface area that will keep the molars distal. So the thing is, the patient always gets off tracking where? Here, in this 2 interproximal area, because the plastic there is very flexible, so it gets squeezed a lot, and it's hard for them to put it in and tuck it in into the right position. So always be a lot of distalization, you need to tell the patient to properly engage the aligners into position, and then use a lot of chewing when they are doing a lot of distalization, especially after 6 start to move. When the 7 is moving, it's not a lot of issues. But when the 6 is moving, 7 and 6 are moving together. There's a lot of movement, there's a lot of small gaps. So it gets off track easily during this stage, about 15 onwards. And then, after 6 and 7 are at this kind of position, we start to move 4 and 5 together. And then there's a space here that we are able to start moving 3 to 3. So that's my protocol, and I'm here to share it with all of you, and then you can try if you haven't tried this type of protocol. But there's a lot of different distalization protocols. You're able to do enhanced distalization, in which you move once, and in which you move 7, 1/3 of the way, and then you start moving 6, 1/3 of the way, and then you start moving 5 and 4, and so on. However, if you move 1/3 and then you start to move the next 2, that means the anchorage is not that strong. Maybe you're looking for moderate anchorage. In good facial profile, you are able to do that. But no matter what, the most teeth you can move at the same time is no more than 3 teeth. Anything more than 3 teeth, you're not going to get good distalization result in your patient. So that is some tips on distalization. So let's take a look at this bimetric protrusion case. She is one of my earlier staff in my other clinic, not my own clinic, when I was still running from clinics to clinics. And then she just came up to me and then she said, I have recumbency on the upper arch and the lower arch. I don't like lips, but I don't want extraction. I only want treatment with non-extraction. And I was like, how can I do treatment on her without extraction, with brackets? Maybe we can try aligners. As you know, aligner is kind of magical for us at one point of the time. So this is her before and after, and then her problem is she's a class 1 bimetric protrusion, no problems. In a lot of bimax, you won't see a lot of problems. That is what it makes the case more challenging. If you see something very straight, you have to be very careful. There's always a trap in that. Because it's hard. You cannot get resolution of the problem and a big change for the patient. You need a lot of bodily movement in order to see a big change in the patient. So there's no crowding, and she has a low tongue position. That's why her upper and lower incisors are more propine. So this is her before and after, before the treatment, the facial profile. So you can see that her lower lip is a bit everted, but she has thin lips on the upper arch. So maybe we can try nut extraction and maybe a little bit of IPR for her. She wants everything as conservative as you know that she's a dental assistant. She knows what is happening, and she knows what will be happening. So she has an acute nasolabial angle. So I designed segmental distalization for her on the upper arch and lower arch. It's a 12-arch distalization. And you can see that on the first clean check, we have 95 aligners. I never tried to do anything with more than 60 aligners nowadays. But in the early days, I tried to be as patient as possible with every single treatment with the aligner system. So the first clean check comes up to about 95. But I think, okay, we can try. We'll give it a try. It's just 3 years, okay, and she is here with us, okay? And then the second clean check, we only use 18 aligners to do the finishing and detailing, okay? So you can see she's a class 1 canine and molar relationship to start with. And then her wisdom teeth is still intact on the upper arch. And we want distalization. So this would be a problem because she is in the more grown adult, grown teenager. She's about in her 17 or 18, which is a hard time. And then, I was thinking if there's the wisdom teeth, then it can reduce the available space for distalization of molars. So we have her to go for extraction before we start her treatment. And according to a recent study and research, they found that from the CT reading, that aligner treatment causes less root resorption and less bone resorption as compared with practice during distalization. And this is a good news because we know that with aligners, it's very precise. With every aligner, it's only 0.25 millimeter of velocity. The friction is really small, and it induces less root resorption. Can you imagine if we have 95 aligners for the first set, and the second set maybe 45, and the third set another 45? It's gonna last for 5 years. If it's 5-year treatment, you have to be careful if there's any root resorption in the patient. So it's good that aligners induces less root resorption, and the incidence of the bone thickness reduction is also less in aligners as compared with brackets. So our treatment plan is to extract upper 8 and do segmental distalization on the upper arch and lower arch, and to increase the buccal root torque on the posterior molars on the upper arch and lower arch to prevent the palatal cusp from hanging down and to prevent the lower molars from lingual tipping. So this is our clean check. As you can see on the upper arch, we did segmental distalization. And since there's a lot of aligners to start with, I changed her attachment to all those conventional attachments that are long, okay, and stable. Because as there's more aligners, there will be more of tracking. The longer the treatment, the more of tracking there will be. So I think that with strong attachments, I'm going to induce less of tracking in her. And on the lower arch, the same. So let's come and see what her treatment comes out. So as you can see, at the end of 1 year and 2 months, there's severe anterior flaring in the anterior region because of the action and reaction force. When you distalize, the upper anterior will also flare. It's just like a pendulum. And this is very evident if you have a lot of lines for distalization, more than 70, you're going to see a lot of flaring, bimetric protrusion, because you are not able to use elastics. Once you use elastics, the anchorage on the lower arch will be compromised. However, you don't have to worry too much because we are going to utilize the damping effect during retraction to reduce the flaring. So it's flaring is not a big issue because we want to retract. And when you retract, it will tip. And then we are able to finish with a good incisor inclination of the upper and lower incisors after there's a large space created. So you can see the angulation of the upper lower incisor initially and at the end of nearly 3 years. So that is because there's the space, and then when we retract, we're able to correct the inclination of the upper and lower incisors. So you can see here with the distalization, aligners are very powerful for molar distalization. Can you imagine the space that's created with all this gum area? You know, it's my passion, it's my love. We're not able to do this even with tats. However, with aligner plastic, with distalization protocol, I think that is one of the one of the key that I'm enjoying aligner a lot, because distalization is so much powerful for our patients. And the amount of distalization, you can see that we are able to distalize 4.8 millimeter on the upper right and 6.1 on the upper left. However, this is on the clean check. So the clean check is about, nowadays, it's about 70 to 75% accurate according to researchers. This is not Dr. Maggie said so. this is a lot of researchers, they indicated that the first set of alignment is about 70 to 75 accurate. So you are getting about 4.2 over there and about 3.5 on the upper right. And on the lower arch, you also get about 4.8 to about 5 millimeter of distalization. Because a lot of doctors, they don't believe that on the lower arch you are able to do good distalization. However, from our cases and from a lot of experienced speakers, they are showing that on the lower arch you also get predictable distalization, spaces from distalization. However, with distalization, there's some disadvantages. Okay, if you are going to distalize it more than 6 millimeter, the treatment time will be long, and there will be severe flaring, anterior flaring, as a result of Newton's third law. And the more aligners there are, the easier to induce off tracking. So patient compliance is very critical. So if you have anything more than 90, maybe you have to try to change your treatment plan from a distalization to distalization plus IPR to reduce the aligner numbers, or to extraction protocol. And try to keep your aligners, each set within 50 to 60 aligners to keep within a good time limit and a good treatment time. And look at her change in smile. It is not the best smile, but she's rather happy because the inflammation on the upper and lower incisor, as you can see here, is not that wrong. It's not that recumbent, and she is good with her face now, and not as recumbent. As you can see, we did some distalization. Okay. No IPR for her. This is the clinic staff. She doesn't want IPR. She doesn't want extraction. She doesn't even want upper 8 extraction. But you need to convince her. You need to make her understand. Yeah. So actually, we learn, from our patient. Yeah. No IPR for her. And look at her X-ray, panoramic. We extracted the upper 8. Okay. This is the position initially, and the position of the lower molar at the end of the treatment. There's some distalization on the lower arch. So the root parallelism is ideal at the end, and the predictability of a long distalization protocol is very predictable. And it's evident in our case, but it takes a lot of time. Okay? I just have about a few, 5 to 10 patients using more than 80 aligners, and then I stop from there. Nowadays, I usually will utilize distalization together with IPR, even though I'm a doctor that does not favor a lot of IPR in my patients. So the key learning for this patient is segmental distalization of 6 millimeter or less is predictable. Anything more than that, you need to tackle it with extraction or distalization together with IPR. The second key point is incisor flaring will be very common and evident in distalization with great amount, but it's not a big issue after retraction. In this line where distalization can reduce the need for tags, for extractions in diametric protrusion patients. So these are some of the key learnings we can see from her case. However, there are a lot of different options that you can treatment plan for her. She can also do IPR 6 to 6. She can also do upper 4 and lower 4 extraction as well. So that is the cases for class 1 clouding and biometric protrusion. And I think biometric protrusion is one of the most challenging cases to treat, not only with brackets, but also with aligners. Next, we're going over to class 2 patients. So with class 2 patients, we know that usually the upper arch is more procumbent, and the lower arch is usually normal or more retroprime, or there's some sort of mandibular retrographism in growing teenagers. So the most common class 2 mouth occlusions that you can see are either large overjet and deep bite, or a combination of both. So what are some treatment approach with large overjet with a favorable facial profile? A lot of doctors might think that I use a lot of MA because I love MA so much. However, I also utilize class 2 elastics in growing kids as well. But how do I treatment plan? Especially in patients with a good facial profile but weak chin, we can utilize class 2 elastic in this type of cases with large overjets. So the first case is a class 2 with a large overjet in which we utilize distalization with the elastic protocol. So we come back to the distalization protocol and the elastics again. So everything is elastic for class 2 and class 3. For class 1, we don't use that much elastics except up and down and midline elastics. So this is the patient before and after the treatment. Okay? He has problems and issues with anterior procumbency, mouth frothing, deep bite, narrow arches, midline deviation, and a weak chin. Let's take a look at his lateral profile. We can see that he's almost like dolichocephalic, and the chin button is a little bit weak. There's no menton. Okay, so I just want to try to protract his lower arch and see whether his growth will help him grow some chin button. The E-line is good. The nasolabial angle is acute. We had 2 sets of aligners for him, and the total treatment time is 2 years. You can see that on the side, it's a similar class 2, okay, not half class C, less than half class. This is a half class 2. So we know that we need to distalize more here, maybe more than 4 millimeters, so that the midline can be coincident with each other. And on this side, we just distalize about 2 millimeters, and we're able to correct the canine relationship of the buccal rat. We can do distalization on the upper arch and then flattening of the curvus B with some intrusion on the lower anterior to correct his occlusion. And this is his wisdom teeth, still in bud stage. And this is the male patient in his about 14, 15 years of age. He doesn't want his wisdom teeth to be extracted because it's so high, in the bone. And the oral surgeon thinks that it's kind of challenging, and there's more risk to extract the upper edge at this time. So I was thinking that, it's still in the bud stage, so maybe extraction is not as critical. So I can just distalize, and then the oral surgeon will have a more difficult time, in the future, because I'll push the edge further, distally. So I tell the patient that we'll just put it there, and we'll see how it goes after treatment. So we can see from this case that even the wisdom teeth is intact. If the patient is a teenager, it's not as critical, to extract the 8 as compared with adults. So we didn't extract, and then we still can get effective distal movement on the upper arch. So the treatment plan for this patient is to utilize segmental distalization on the upper left, because the canine relationship is a half-half canine relationship on the upper left. And then to do anterior retraction to correct the midline, after it moves distally on the left side. And then class 2 elastics only on the left, and mandibular advancement with the elastic layer. So this is a simple treatment planning for the case. Let's take a look at his clincher. So on the upper arch, we did segmental distalization over upper left, as you can see here. And the IBR over the anterior, especially the upper left, because I want to get space for midline correction, and class 2 elastic on the left, okay, to correct the canine relationship. However, can you see, I wasn't very careful in modifying the ClinCheck over here, okay? So there's a big bulge between canine and premolar. The premolars are more extended than the canine. So we did segmental distalization, okay? The patient starts with overjet of 7.6. It's a very big overjet. Sometimes he's required for mandible advancement or functional climbs, but since he has a dolichofacial tendency, I didn't put him on functional climbs because I don't want to increase his vertical dimension on the posterior. So we just did class 2 elastics, and then the overjet is 7.6, and with the elastic, we're able to correct the severe overjet relationship. This is him. He's a very compliant patient. As you can see, from just 5 months of aligner wear and elastic wear, okay, the midline is on, okay, it's a bit what? The expansion on the upper arch is not good enough on the upper right. So this tend to be edge to edge on the posterior segment. Over here, almost class 1, okay, in just 5 months. Okay. So I continue to give him class 2 elastics and vertical elastics. So class 2 elastics here, okay. Over this side, vertical elastics to help with the bisettling, and then we go into AA to do more extension on the upper arch. This is the upper arch form and the lower arch form. Okay, the arch development is good. The changes in the overjet and overbite is evident. After he finishes first set of aligners, we can see there's a lot of posterior open bite. Okay, posterior open bite, posterior open bite. So on the second set of aligners, we try to do posterior bisettling and then arch coordination for him. And on the lower arch, the same. So let's take a look at this ClinCheck. So you can see there's a lot of extrusion with attachments on both buccal right and buccal left with about 35 aligners. So with posterior bisettling, we need to check if the upper arch is not wide enough, there's not enough clearance of the buccal overjet and overbite over the posterior premolar and molar area, you're not going to get a good bisettling because there will be a lot of interference. So in order to get a good posterior bisettling, we need to do expansion on the upper arch and then extrusion of premolars and molars. So that is some key points to take note when we are doing bisettling in very narrow arch form on the upper arch. And this is the patient before the additional alignment and after the additional alignment. So the interdigitation is good. And usually I will try, especially in teens, without up and down elastic first. And then if the settlement is not good, I will use the last 2 to 3 aligners in which I'll ask the patient to wear for 2 weeks or more, in which I will bond the button and button hooks and ask the patient to pull triangular elastics, okay? And then I'll cut the aligner. On the upper arch, I'll cut between upper 4 and 5, so that there's clearance over 5, 6, and 7. When they pull the elastics, the teeth will come into occlusion. Okay? It's easier. Sometimes you can ask the patient to just pull the elastics all day without aligners in the morning. At night, they wear the aligners and they pull the elastics together. so that there will be less friction and less coverage of the plastic, so that the patient is able to settle the posterior premolar and molar into position easily. And on this side, we cut between 4 and 5 on the upper arch, and the same on the lower arch. And usually, I will not instruct my patient to pull more than 2 triangles at the same time on each quadrant. So after this is fixed and everything is good here, we can move one more teeth distal. If you ask them to pull 3 triangles, sometimes it's hard for them to use and they will get less compliant. So it's better to correct the anterior first, and then we work till the second molars. And this is the arch form of the little young boy, young man, okay? The arch form is good, and look at this facial profile with just the class 2 elastics. So even without the mandibular advancement, you're able to grow the chin. Not because of the elastics, but because of his growth potential. Because there's no interference, the mandible is not locked posterior. The mandible is able to grow because the mandible, there's freedom on the condyle, and there's freedom for the condyle to grow. Usually the condyle doesn't grow because it's very intact with the condyle, and the condyle head is in a more posterior distally position. So you need to move it forward with the elastic and allow freedom for the bone to deposit over the condyle and glenoid fossa. And this is the initial and the final panoramic. You can see that the aids are still there, okay? However, we're able to get effective distalization with no extractions, and we're able to correct this large overjet without the wisdom teeth extraction. So if you are treating a teeth and the wisdom teeth is still intact and you want to do distalization, I think it's not a big issue if it's still in the bud stage. However, if the roots are starting to form, especially in females, they tend to form earlier than male. So if the male, they don't want the wisdom teeth to be extracted, I think it's good. However, for female, always check if the roots start to form or not. If it starts to form, maybe we need to suggest extraction of the wisdom teeth in order to get more effective distalization results. Okay, and this is the young man before and after. Look at these changes in the overjet, and the angulation of the upper and lower incisors are maintained. So the key point here is, for this class 2, the elastic protocol, together with distalization to correct the large overjet, is to tackle segmental distalization with patients. Okay? If there's off-tracking, start to happen early, don't go on to the next aligner, or don't go on with AA. You need to go back and ask the patient to use the chewies and to engage the aligner, especially the interproximal segment, into position. And if the aligners are bending, okay, you need to bend it back so that it's flat on the surface. If it's bending, you help the patient to bend, to that bend. As you will bend the wire as well. You do aligner plastic bending. And then utilize distalization in class 2 in very large overjet. And you also get good facial profile as well, as long as the patient is compliant, as long as the patient has growth potential, and as long as the genetic in the patient allow the patient to grow in a good direction. And prescribe molar extrusion in lower facial height patients, so that they have more elevation of the vertical dimension of the lower facial height will increase. And it's good because with the class 2, the lower molar will extrude as a result of the class 2 elastics. Okay, so that is the key learning for the class 2 division 1 with elastic protocol. we're going to stop here, okay, for dinner, and then we'll come back after dinner for further case discussions. And I'll stay here if there's no questions for me.